Hello, hi everyone. Happy International Women's Week. Welcome to our discussion on empowering women's health, accelerating action for reproductive well-being. My name is Dr. Wamboi Mutura, Britam Wellness Lead, and in this special International Women's Day conversation, we spotlight reproductive health as part of wellness. We are committed to promoting preventive and promotive health while empowering women through knowledge and access to the right resources. Today, I'm joined by two incredible gynecologists. We will delve into menstrual health, childbearing, family planning, menopause, and more. We'll discuss practical steps on how accelerating action can transform women's health outcomes. This conversation is part of our ongoing commitment to support our clients with the tools needed for better health and well-being. Let's continue this journey towards healthier, more empowered women everywhere. Hello and welcome, ladies. Please introduce yourselves. Doc.
Oh, happy International Women's Week. My name is Dr. Muthoni Ridho. I'm a reproductive health specialist, a consultant obstetrician gynecology with special interest in reproductive endocrinology and fertility. And I work at the Women's Clinic Medical Center. And this will be my colleague. She will introduce herself.
Thanks for having us. My name is Nyawera Wahome. I'm an obs gyna. I work alongside Dr. Muthoni and Dr. Ngayo at the Women's Clinic Medical Center, and I'm happy to be here and happy International Women's Week.
All right, thank you so much. We clearly have the right people in this conversation. Please tell me one thing that you're celebrating in this period, this International Women's Week.
So this International Women's Week, I'm especially excited because we're starting to listen to the women. We are centralizing the voices of women and uplifting them, which is important in helping women take center stage and responsibility over their reproductive health, unlike traditionally, where other people were the ones taking the lead in the conversation. This time round, we are taking the lead.
All right, Doc.
Yeah, so I echo Dr. Muthoni's words. I think I like this year's theme for all women and girls. So, we're doing a good job to get women's voices out there. And now, we should also pull in the girls because we start off, that's where we come from. Yeah, so it's not just now for women, it's also for the girls, the girl child, right from beginning.
All right,
Yeah.
So thank you, Doc. So as you said, the theme this year has been for all women and girls, rights, empowerment, and equality. So how do you relate this to reproductive health, this theme?
So this year's theme is quite important because if you look at the keywords, we have rights, we have equity, and we have empowerment.
Yes.
You cannot have empowerment unless you look at reproductive health as a right that is actually ingrained in our constitution. But if you look at the definition of the reproductive health, it's quite wide. It's not just absence of disease. It's basically physical well-being, mental well-being, and social well-being. So we focused a lot on the health aspect, but we have forgotten the social aspect and the mental aspect. And when you look at women and the things they go through the reproductive health cycle, it has a significant impact on their social well-being and their mental well-being, which also affects their ability to be productive citizens and to live a wholesome life.
Okay. Doc?
Yeah, so for me, this year's theme, I'm happy that focuses on the girl child. I think in recent past and post, within COVID era, post-COVID era, we've really seen how adolescent girls are very vulnerable. And even young women are extremely vulnerable. We've been having teenage pregnancies, we've been having femicide. So I'm happy that this year's theme incorporates them. Reproductive rights is core to being a woman, so yeah, if we have a platform to speak about it, yes, we have an opportunity to engage lawmakers, people in boardrooms pertaining to things that are hurting us as women, or will benefit us as women,
Thank you, Doc. I think there's a very important point you brought in about femicide. And at this juncture, I'd want to ask, where do you feel women are disadvantaged with regards to their reproductive health in the current world that you're living in today?
So women are quite disadvantaged in almost all spheres of life. Like when you look at us, most of us who are professional women, our reproductive health sometimes directly affects our productivity. If you look at childbearing, when you're pregnant, you cannot work as hard as your male counterpart. When you take maternity leave, you are actually away from the office for a while, so you'll be in a high pressure occupation, or you're needed to meet deadlines, you'll fall behind your male counterparts. You also have the issue of taking time off to take care of your baby, maternity leave. It has currently been 3 months. Not all organizations actually give the whole 3 months. Then there's the small challenge of breastfeeding until the baby is weaned. So even after you go back to work, you realize you're lagging behind your male counterparts, which makes women sometimes miss out on promotions, miss out on traveling, sometimes actually take unpaid leave from work to be able to take care of their families. Also, when you look at our reproductive health, our menstrual cycles, there's a part of the cycle where you're rather emotional, which can actually impact on your relationships with your colleagues. Some women have difficulty or trouble during their menses. Their periods are either very painful or very heavy. Sometimes they have to work from home or take time off work. Then also when you look at some of the things you go through when you're having our menses, people trivialize it. Like for a very long time, women have been told painful periods are normal. So even when you want to tell your boss or your colleague, I'm struggling with your menses, they're thinking, isn't that a normal thing? And you see that also makes women feel unable to express or feel unsupported in the environment. And also when you're looking at the older women, the menopausal women, they have to be in boardrooms, they have to do their presentations, they're struggling with hot flashes, they're struggling with sleepless nights, they're struggling with mood swings. So you realize sometimes they feel disadvantaged and sometimes not supported enough in the environment. I think Dr. Nyawira can add a few more pointers.
Yeah, maybe just to add on there, I'd say another way we're disadvantaged is a lot of the time as the women, in terms of their health-seeking behavior, is greatly affected with, male figures in their lives. Often women will come to the hospital and say, okay, I waited for my husband to come, or, I needed transport or money to come. So, from that point, we are a bit disadvantaged because our health-seeking behavior is almost, in a lot of the time, dependent on this male figure. And then, another way we are disadvantaged is just that trivialization. I think we haven't yet, we are still and we're growing to accept women's statements at face value, instead of, that stereotype of she's being emotional or she's being aggressive, or, it's, we still need to come up and own our, respect our voices, as legitimate concerns. If you say man flu deserves like a week of rest, so so periods also need that same space. Another good example, condoms, contraception for men is free. There's funding for that. Pads for women, we are still looking for funding so that we make pads available. So, we are still disadvantaged, and International Women's Day, International Women's Week, it's just to try and bring these conversations to the fore so that we continue to think about them. Yeah.
And to add on to what she said, there's also the aspect of autonomy. Like we've had a conversation that's been going on recently, to have children or not. Can I have a permanent method of contraception even if I've not had my children? You see, there's still a lot of stigma, a lot of judgment. If you choose to have children, there are too many, there are too few. If you choose not to have, why don't you want to have? So there are a lot of issues going around autonomy. And when you look at the younger woman, which is a girl, we also have specific problems in our country that still plague us. We still have adolescents being married off, being taken out of school. We have female genital mutilation, which is actually considered gender-based violence. We also have sexual assault and physical assault, which is also part of gender-based violence, which is commonly tied with women not being empowered. You realize most of the places where those things go on, the girl child and the woman are also not quite empowered. And for us, a difficult challenge we have is how to deal with culture in respect to reproductive health. Because when you look at even marrying off children and FGM, it's a lot to do with culture.
Definitely.
Even our health-seeking behavior. If you look at the older women, they don't talk about reproductive health. If you look at one of the challenges we have, which is cervical cancer, it presents with bleeding post-menopause. But by the time that elderly woman says she's bleeding, probably the cancer has advanced because she's unable to speak out about her symptoms, which are considered taboo. So if you look at the full spectrum, we all have different challenges, and some of them are difficult to navigate. Yes, especially when you look at culture, when you look at poverty. She talked about menses, pads. It's been very difficult to navigate these. But in the end, they all disadvantage the female, whether it's the young female or the elderly female. Yes.
So thank you very much. I think you've brought in very important aspects of generally women's life, and Doctor, is that aspect of brought in of where women are referred to as being too much. So when you do this, you're too much. When you're very vocal, you're too much, which has also disadvantaged women in the long run. So here we're going to look at the life cycle of a woman, the different challenges that they are bound to face with relation to their reproductive health. So we'll start with in their teenagehood. What challenges are these that women are likely to face, and how can they overcome these challenges?
Yeah, good. So teenagers, young girls, they're just, getting into, they're in that space of peer-to-peer, what's that word? Influence. They're highly influenced. They're in a very stressful period of their life. You look at your other friend. Anyway, it's if I remember, it's just a stressful time. And you're coming to know yourself, you're trying to establish yourself, your personality amongst your peers. And then now come periods. So yeah, girls usually should get their period between 10 to 15 years. It's a new shift for them. So they've started experiencing puberty. There are all those puberty changes. They may gain weight. They'll get breasts. They'll add, the weight will be will be specifically distributed around hips, around the upper arms, face, and all of these. And then usually that precedes the occurrence of the period. So usually puberty will come, and then what we call menarche will follow. And so she may experience her first period in that space of 10 to 15 years, commonly around 12 years, but within that 12 to 15 years. And I think we should be doing a good job to prepare our girls for that. I think by and large we do. A lot of the time it's also, so-and-so has started, so-and-so has started. So there's also that peer, information that passes through. Normally, what the girl should experience is just a period between 2 to 7 days. They normally tend to be on the 7th day side rather than on the 2nd day. So most girls will bleed 5 to 7 days. They may be irregular from the beginning, and they may be painful from the beginning. So I'd say if I think of the challenges that she would experience is how to navigate, menstrual hygiene now as a teenager amongst people around her, how to navigate the symptoms that come with periods, and then I think those are the big things and then how to manage now the patterns of their menstrual habit, because in the first 3 years the periods tend to be irregular. They may skip from month to month. They may come very close together. And then usually anyway, for most girls, it mellows out and settles, from around the 4th, 5th year of their period starting.
Okay. So we could say around the irregularity around this period would be normal.
Yes, it should be normal. It is normal. It's normal. Yeah. So that's the other thing. Maybe we should, something we can talk about now is what's normal, because it's something new, and the girl doesn't really know what's really normal, what's not normal. Yeah, so a normal period is between 2 to 7 days. A normal period should have a normal flow. They may use about 3 to 4 pads per day, maybe or 10 to 15 pads per cycle. A normal period should have maybe day 1, day 2 pain. That is easily managed with just simple activities like maybe a hot pack or exercise, and should not disrupt their routine activities. So going to school, yeah, and playing sports, it shouldn't. Though that's a normal period, it shouldn't disrupt. Yes, we may get months where they skip, and also that's normal. Yeah.
Okay. All right.
Then in addition to what she said, sometimes with the hormonal changes they get, they become prone to getting some forms of infections. The commonest is a yeast infection.
Okay.
It may afflict quite a number of these girls. Sometimes their parents misunderstand it to think it's a sexually transmitted infection, but actually it's not. It's triggered by the hormonal changes that the girls go through as the cycle changes. Unfortunately, in this period, some girls tend to get sexually active. So when we are seeing them, sometimes we tend to inquire about this because sexual activity brings its own sets of complications, including sexually transmitted infections and unwanted early pregnancies. So those are the other conversations you need to have with these girls. It's also that age where they want to experiment with sexuality. So age-appropriate sexual education becomes important in this stage. Yes. And then also when you're looking at menstrual health, like Doc said, it's important to educate the girls on how to use the menstrual health products. If it's a pad, how long should you keep it on? How do you discard it? The same thing for tampons, the same thing for menstrual cups. So we avoid complications that can come with improper use of the menstrual hygiene products like burns from pads or even life-threatening infections from a tampon kept on for too long.
Okay.
Yes.
All right. All right. So that's a conversation parents should be open to having with their children.
With their children. Yes.
All right. I would also like you to describe for us, for someone who may not know, how the yeast infection presents, especially in these children, so that if parents see this in their children, they'll understand where this is coming from.
So a yeast infection would typically present with some irritation around the genital area and some discharge. Commonly, it has no smell, usually white, curd-like like yogurt. And sometimes there may be some skin irritation that forms some bumps. Yes.
All right, all right. So that should be considered around when the periods are starting. It's a normal occurrence unless there are other things that are coming into play.
Actually, we don't consider it normal. What we recommend is in case the symptoms occur, that they see a health provider and have it treated and maybe address an underlying factor if present. Yes.
All right, all right. Dr. Nyawira, there is a shift we are seeing where menses come even earlier. You've pointed out 10, but we are seeing children as early as 9 getting their periods. Is this normal, or what would be contributing to this shift?
Yeah, that's a good question. It's not entirely normal, but it's, I think if periods come below 10 years, it's always good to probably visit, a reproductive health specialist. But that trend comes also from something else that's happening. This weight and weight management in both childhood through adulthood. So, we're beginning to be an obese population, and children are gaining or are having inappropriate weight gain in their childhood. That actually now is what bears into when puberty will start. So if children are obese, they may get their periods and they may go into puberty earlier. So when you think of obesity or that may be familial, so there are some situations where it's familial or actually there's an organic issue underlying, but a lot of it has to do just with the lifestyles, what we're eating, Yeah, and I think those things are now, that's what, plays out and has impact on when puberty will start and when the periods will start. But there's a few conditions which result in early periods, and I think if it happens that the periods come very early, it's just good to still be checked. Yeah.
All right.
And also to add on to that, maybe what can help you understand it easier is when the girl's weight reaches a minimum threshold, the periods will come. So if you achieve that threshold earlier, like she said with obesity, then the periods tend to come earlier. And actually, traditionally, women used to get their periods in their late teens. But right now, even 8 years, we consider it normal. And we just empower the girl child to manage her periods. Yes. But like she said, it's always good to check for other health conditions that can trigger early periods, which are abnormal.
All right. All right. So thank you. Very great insights on teenagehood. We'll go to the middle reproductive years as the next stage in the woman's life cycle.
So in the reproductive years, again, you have problems with menses. And the problem with menses can be they are too frequent, or too few, or too heavy, or too light. Or you can have something we call premenstrual syndrome, which comes with its sister, which is an extreme form, which is premenstrual dysmorphic disorder. We'll talk about that in a bit. And then the thing to note is at this stage, we have expected the periods to have stabilized. So if they still haven't stabilized, there's most likely an underlying condition. Remember, Dr. Nyera had said in the initial years, irregular periods or changes in flow could be normal because it takes about 2 to 5 years for the hormonal system to stabilize. But by the time you're a middle-aged woman or a woman in your 20s, they should have stabilized. So if you have any problems with any of those things, then most likely there's a medical condition that needs to be addressed. Then the other challenge we have with women around this age is hormonal imbalance. The commonest form of hormonal imbalance you have currently is polycystic ovarian syndrome. I'm sure you've heard a lot about it.
Yes.
I'm sure it's one of the buzz topics currently. The other issue we have with women this age is infections, genital tract infections. Some are sexually transmitted, some are not. Again, in these women of this age, you start getting risk of reproductive tract cancers, the commonest ones being cervical and ovarian, but also breast cancer is starting to affect women as early as their late 20s and early 30s. So that's another thing we need to pay attention to. We also have women who are trying to get pregnant or not wanting to get pregnant. So the ones not wanting to get pregnant will be seeking contraception. The ones wanting to get pregnant and are not able to get pregnant will be seeking fertility treatments. So those are the commonest ones. And also to add on, when you're looking at periods, one of the things that has been causing painful periods is endometriosis. I'm sure you've heard a lot about it.
Yes.
It's one of the buzzwords. Maybe Doc can add on.
Let me put in there, we should have mentioned it with the teenagers, but yeah, HPV vaccinations. Yeah, so teenagers are exposed to, there's sexual debut actually on average is around 15 years. 18 years, I think, 18 years in our context. So when you think about a target population to do HPV vaccination, HPV stands for human papilloma virus. Yeah, it's this group of girls, young women who either are sexually naive or have an early sexual debut. Yes, we target that group. For endometriosis, secondary, there is that misnomer that periods should be painful, and actually they typically aren't. Most women don't really get very painful periods, especially once you come into your 20s, your mid-20s and going forward from there, the period pains tend to subside. So you have, your teenagers would be the typical people to come with period pains, and even then it is just what we call it primary. It improves with just simple remedies. And then you come to your 20s, and now, you know, your normal Panadol doesn't do the trick, or Buscopan, people know Buscopan, or Ponstan. Yeah.
Those are the common ones.
Or a hot water bottle. You try all of these typical remedies, it doesn't work. Yes, that becomes the red flag to say maybe my pain is actually out of keeping. Yeah, so there is such a thing as period pains because of another cause. And that other cause in our setting is frequently maybe something we call endometriosis, adenomyosis, maybe fibroids, but those would be the big three that give period pains. Yeah.
Okay. So you said as women grow older, their period pain should be subsiding, should be getting better, as in comparison to how they were during their teenage years.
Yes.
There are these women who get new onset period pains. That this is someone who has never experienced any period pain in their
Actually,
teens.
that's a great question, because if it comes and you've never had it, it means something has triggered it.
Okay.
So you need to see your doctor to figure out which of the causes of period pains you have developed. It's unusual for it to develop from the blues. And that's now what we call secondary period pains, or secondary dysmenorrhea, meaning it's being caused by something that we need to figure out and manage it.
Okay.
Yes, so that at least your menses are a bit more bearable.
All right.
Yes.
All right. So then I'd like us to delve a little bit more into the PMDD, PMS, that whole syndrome, because I've seen it's something that is coming up. You can see it on social media. People are talking about it. Oh, I have PMS. Maybe you could decipher this for us so that people know what exactly this entails and how it has a tying with the mental health aspect, that is the PMDD.
So usually, maybe we can start from the simplest form. In the second half of the menstrual cycle, after a woman ovulates, there are some hormonal changes they undergo which trigger certain changes in her system. And one of the common things we would experience would be things like bloating, things like shortness of temper, difficulty in sleeping, what else? Headaches, a bit of nausea, and the symptoms gradually increase in intensity and are worst just before you start the menses and the first one day of the menses. So it is a normal process, and we consider it what we call physiological. However, for some women, it becomes exaggerated, and you have this premenstrual dysmorphic disorder. That's the full name of PMDD. So the important thing about PMDD is that it affects the woman's mental health significantly. There's actually a criteria we use to, if you meet the basic criteria, then we diagnose you with it. But some of the components of the criteria include, maybe you can contribute to it.
Labile moods. Yeah, so PMS is short-lived. It's like it heralds just before the period starts and then disappears once you are like on day 1, day 2. PMDD persists. So you have these mood changes that just now last longer and now affect your ability to interact with people. Yeah.
So more like how the depression presents, a mild form of
In
depression.
addition to that, they report depressive symptoms, and depressive symptoms are varied. Maybe you don't want to talk to people, nothing is making you happy, you feel your mood is depressed. It can come with anxiety, it can come with suicidal ideations. It can come with, it actually makes the women feel incapacitated to be productive. So it's actually an extreme form of the mental changes you get with PMS. And if you fit that criteria, then you need to actually be put on proper treatment, which includes maybe some antidepressants, some anti-anxiety medications. Sometimes you may want to suppress your cycles altogether because your cycle is dependent on the hormonal changes that come with ovulation. If it's really bad, you might want to knock it off altogether so you don't get those hormonal peaks and drops which trigger it. Yes.
Okay, all right. So that's a big thing. I think it's a big conversation, and I think right now with the new age of social media, social media has its ups and downs, but with information, with the right information, people are just actually getting to know that you might, the people who are feel so low just right before their periods, and this continues, and they probably think this is normal. But when you come to learn of this information, then you know actually this is not the right thing, and I should probably get seen. All right, family planning. Want to weigh in a bit on that? There are a lot of questions that come in. People will ask you, I'm sure, being a gynecologist, I'm sure every family gathering or every public gathering, which is the best contraceptive? That is the question everyone asks. What should they be on? Maybe now you can
The
demystify
$1,000,000 question.
Yeah.
Which is the best contraceptive method?
It's like asking which is the best rice to buy. Okay, I don't know if that's, I don't know, let me relate it to guys.
Which is the best brand of socks?
or
I don't know. It's an interesting question. But for me, I usually try and simplify it as a necessary evil. I know hormones have been demonized in the recent past by saying, oh, they're interfering with your natural body. However, for some women, they actually need it. Because see, when you look at contraception and family planning, there are two aspects to it. Number one, you need to be able to space your pregnancies. You see, one of the functions of family planning is to space pregnancies. Like you don't want to fall pregnant so soon after you've had a baby, to give your body time to recover and to give you enough time to take care of this child, ideally at least 2 years. Because we want you to breastfeed, you want you to win them, we want you to be physically and emotionally available for this child so that they don't even get those problems they have with growing up. Then number two, if you choose not to get pregnant, then we need to give you a way to not get pregnant until you're ready to get pregnant. So we consider it a necessary evil. As to what is best, honestly, there is no best. It just works to work for you. Like I usually tell people, it's like a boyfriend. What works for me, maybe Nyawera said, even with a 10-foot pole, cannot work for me. So it's a difficult concept. Some women will swear by this method, another one will swear by another one. So there's none that is ideal. But to put it simply, we usually have a medical criteria that we use to tell you which methods would be suitable for you. And then depending on the criteria, would offer you the option, then you pick the one you feel might be best for you. And the good thing about contraceptive methods is that it's not a permanent decision. If at some point it stops working for you, you can stop using one method and go on to another method. And we offer all contraceptive methods, ranging from natural all the way to the hormones, to the non-hormonal methods, even the permanent methods, depending on the stage of your life.
All right.
Yes.
Okay. So I think the take-home message here is that there's no one size fits all.
Yeah.
Something might have worked perfectly for your friend. But when you try it, it's just
it doesn't. Yeah. Maybe and then also just to throw it out there that it's for both men and women. Yeah. So both partners can take it up. Yeah, the responsibility. I have a friend, I don't know if this is for mainstream media, but or side room chat, but I do know some couples who the guys use withdrawal method, and they've been married for 10 years now and they have 2 children in that. So I mean it's working for them, so we shouldn't restrict the burden or quote and unquote the responsibility for contraception to the women.
Yes, and also on the same breath, when you look at contraception, it goes hand in hand with fertility awareness. Like the converse is true. For the time you want to have a baby, if you want to practice natural family planning, you need to be aware when your body is fertile and to recognize the changes that come when you're ovulating, so that you also know, if I want to have a child, this is my fertile window. Or if I don't want to use a conventional method of contraception, this is a period where I am unsafe and I either need to abstain or use another method,
a secondary method
of contraception. So they go hand in hand. So that's what we say. It doesn't mean if you're on family planning, you have something stuck inside you or you're swallowing something. Sometimes it's just practicing fertility awareness. I know this is my fertile time. I need to manage my fertile time, how me and my partner feel, it is appropriate.
Mm.
Yes.
Okay.
So we open it up to include everyone, including the ones who religion or other things prohibit them from using
using certain
conventional or
methods.
modern methods of
Yeah.
contraception.
It's really, which shoe fits. Which shoe fits.
Okay. All right.
And the controversial area we've had with contraception is with the teenagers who are actually sexually active. It becomes a
thorn in the flesh.
because from a medical perspective, you're thinking, oh my God, I want to protect you. But also you look at it from the other concept of who will consent for you. When you look at our legislature, it doesn't
allow
us to
below
give-
18 consent.
Yes. So it's a bit of a dicey area because there's still girls at risk of getting pregnant. But hopefully moving forward, we will have a solution for our teenagers who are sexually active. Because if you're already sexually active, you cannot tell them stop.
Yeah.
If they choose to,
That's a choice.
yes.
Alright.
So that's one of the dicey areas we have.
Yeah.
And also to mention, contraception should be continued until after menopause. You know, there's this thing women assume, I'm in my 40s, I can't have a baby.
Yeah.
It's a misconception.
Yeah.
Please, if you need to continue using a fertility awareness method or contraception until you have achieved menopause.
Before we even move to the twilight years, or as we move to the twilight reproductive years, would we say the choice of contraceptives being almost, it's a role of the woman, would this be an area women are also disadvantaged?
The fact remains, there are more methods for family planning for women, or rather choices are more for women than men. You know, as women, we have access. We can make good choices around the options we have. And it would be great, yes, let our partners come on board so that we own it as a couple. You know, at the end of the day, I think it enriches relationship when even that is shared. You know, we always say a burden shared is a burden halved. I think it should be an open conversation. Let people come to that decision together, not like how it commonly is. You go to the doctor. Yeah, you just go. I'll be here waiting for you.
But also, in addition to what you say, Doc, you realize the burden of pregnancies on a woman.
Yeah.
So the burden of taking responsibility to fall pregnant or not to fall pregnant, I say, is a selfish decision that a woman has to make.
Okay.
All right? Because if you don't take responsibility for your reproductive health, you will bear the brunt of that
The
burden.
consequence, yes.
Yes.
Yeah, squarely lies on the woman.
Yes. So as much as you'd want to have the male partner involved, they're also disadvantaged because the only methods are available to men currently are either the male condom or the permanent method, which is vasectomy. And when you look at it from a cultural perspective, vasectomy is not easily acceptable. Of course, there have been campaigns to popularize it, but there's this whole misconception of vasectomy being related to impotence. Of course, they're not, but you see, it's culturally ingrained. So if a man undergoes a vasectomy, he feels less of a man than his colleagues.
Yeah.
Then also, secondly, the acceptance of use of condoms in long-term relationships tend to be very poor, which also disadvantages the women. So in the end, I say, you have to take control of your health. Because you're the one who will bear the brunt of your decision. Yes.
Yeah, okay. All right. Great insights there. Thank you, Doc. So on the twilight reproductive years, what challenges are we looking at?
One is most of the time in where the periods get lighter. Actually, generally, that's what happens. Periods start heavy, and as the years go on, they tend to reduce. So you start 5 to 7, you move to maybe 3 to 4, and by the time you're hitting your 40s, you're like 1 to 3 or 2 to 3. So that's what normally we should expect. Challenges come actually mostly because of the withdrawal of estrogen. Yeah, we have two main hormones that drive our reproductive system, and that's estrogen and progesterone. And it's okay to have that estrogen withdrawal because, you know, it's let me say, it's God's design. Estrogen is like it's like fire in a woman's body, and if you're always exposed to that heat, some of the tissues that respond to the estrogen may be overstimulated, and as tissues age, it's just like a vehicle. You will be able to run a vehicle at peak performance only for a given time, and later on, when the nuts start wearing and the bolts start wearing down, you reduce the intensity of that of the work of that vehicle. So it's the same thing in our bodies, and estrogen needs to come down so that we spare the cells from further activity that would otherwise then drive them or tip them overboard. So that's really the essence of coming into menopause. It's just to kind of let the body woosa now. Unfortunately, yes, it comes with its set of problems, which are actually just, they're all mediated by estrogen or heavily mediated by estrogen. So one is sleep, mood, our cardiovascular health, weight, the periods themselves, yes, childbearing, skin, targars, bone mass. If we think of just, equivalent in men, and they also have their version of menopause, andropause. The moment we withdraw the estrogen, bone density goes down, muscle density goes down, those two curves start flattening. And it's okay, it's part of life. So menopause is, it's just managing that withdrawal, managing then the new you. Now you are a new person without estrogen, and navigating life in that space.
Then in addition to what she said, we also have the usual health challenges women get. Again, the menstrual health. You can have heavy periods, painful periods from other reasons. Commonly around this time, you'll have a lot of adenomyosis, you'll have some fibroids. The risk of reproductive health cancers still stands. I'm very passionate about this because we need to screen cervical cancer, breast cancer, and also ovarian cancer. The risk still stands. They're still at risk of sexually transmitted infections because women are still active at this age. They're also at risk of getting unwanted pregnancies, and the ones who are trying to get pregnant will suffer from decreased fertility, right? Yeah, so the other conditions still occur at this time. So it's good to be cognizant that besides perimenopause and menopause, we also have all the other reproductive problems occurring in this time. The same way you had a transition from adolescence to puberty and having your menses. No, menopause is the reverse. You're transitioning from having menses and ovulation to no menses. Yes, and also having the reproductive hormones decline over time with the attendant symptoms that doctor has listed. Yes.
All right.
So even in that age, reproductive health care is still very essential. Yes.
All right. Could we talk about mental health in this period? Because I think mental health is a very big thing around the twilight reproductive years. That when you're saying the estrogen is withdrawn, or it's coming down, then there are all these changes associated with this, then that takes a toll on the woman's mental health. So maybe we can have a conversation around
So
how
yes,
that
it does take a big toll on the mental health because some of these reproductive changes are quite distressing. You're not sleeping. The more you don't sleep, the more unrested you are. You're unrested, you're expected to go to work. You end up at home. You get anxiety, right? So they're all interrelated. And also these mood changes that you get, they interfere with interpersonal relationships. The interpersonal relationships are in all spheres of life, whether it's you and your partner, you and your children, you and the people you work with. All those relationships tend to be affected because of this shortness of temper or people retorting or snapping back, okay? Then also, if you're especially vulnerable to getting depression, you're likely to get it at this point in time. There are some people who are always vulnerable to getting depression and suffer small mini depressive states. At this time, it can be unmasked, and you can actually suffer major depression, which might require treatment. Also, the women who tend to have anxiety, just subtle anxiety, at this point in time, it can be unmasked and you get the full-blown anxiety episodes. Yes.
So this is still related to the
It's
fluctuating
related to
levels
the
of
hormones.
estrogen.
Actually, science has told us the fluctuating levels of hormone in the body can trigger mood changes, which for some women can be a full-blown condition. The same way after women deliver and the hormones drop, they get postpartum depression, postpartum anxiety, postpartum psychosis. It's all related to hormones. So at this stage, which is menopause, that drop in the hormones can do the same thing and can trigger a full-blown disorder, mental health disorder. But even the ones who don't need medication, or it's not as bad to need medication, also will suffer from those things. Yes.
So it's something that people should be aware of.
Yes, in fact, they say practicing mindfulness. They say mindfulness starts by being aware of your internal environment and how it's affecting your external environment and how you can make changes to alter those interactions so you have a harmonious existence. So actually one of the things I tell my patients in any of these transitions is to always practice mindfulness, because when you're self-aware, then you know what you need to change so that you don't cause a cascade. Like that thing for cats, a domino effect. Yes.
It's crumbling.
Yes. So it actually it helps women quite a bit. Yes.
Okay. All right. So thank you for that. When we look at menopause now, that should be towards the end of the woman's reproductive age, many things happen. And I think I like the way these days women are very self-aware, and I'll see them with a fan on in the boardroom even. They'll even have these electric fans and they'll be moving around with. But I'd like to understand these changes during menopause. Are there things that women can do as home remedies or as remedies to counter, because we all know this, or you'll also highlight on the symptoms that come with this, as well as the remedies. Then also touch on hormone replacement, because I think that is a big thing that is, it's also, I'd say, a buzzword that's also going around. Yes, I think you should also look at that.
To go?
Okay, go for it.
Yes.
So remedies, they're just normal routine practices that you can incorporate. Then you build up to lifestyle dietary modifications. Then you build up to additives, herbal additives. And then from there we build up to hormone replacement therapy. Yeah, and maybe if you don't want to build up and you want to jump across to hormone replacement therapy, that's fine. We all have different needs. Some people are in the boardroom, some people are at home, some people have more severe symptoms, some people have subtle symptoms. So I think the best place, a place we usually start is like, let's just assess what your need is. And there are actually tools that we use to assess those menopausal symptoms. Yeah, based on the tools, even now, it also helps to make the person aware, okay, this is me, this is where I'm at, or this is where I may be going. And then you can also stagger your care based on that journey. Yeah, so options include, lifestyle modification includes things to mediate sleep. So exercise is good. There are definitely routines are usually good for sleep. So here's a way you may be able to now, wind the body down and just have a pattern and a routine for sleep. That may also help in terms of the onset of sleep and training your body for that. We did for children, can also work at this time. Some of the things we eat can also affect our sleep. So stimulants will definitely, or rather would avoid stimulants towards the later part of the day. Then there are medications that we can use, such as chamomile, or herbal things, chamomile, evening primrose. They're all useful for sleep. Yeah, melatonin. Yeah, those are all additives. They are over-the-counter additives actually that we can we can use. Vitamin D supplementation is also has implications in sleep and mood stability. So, we screen for that, we check, we're deficient in vitamin D. It does a world of difference when you supplemented for it. So those are the simple things that we can do. And then HRT and phytoestrogens. Doc had mentioned it earlier. They're like estrogen-like compounds that are found in our just normal foods, different foods, specific foods, almonds, soy, and they will at least complement your inherent estrogen production. So these phytoestrogens are useful then now to kind of maintain that level. The benefit usually for all of these lifestyle and dietary modification is gained when you do it routinely for a long period of time. Yeah. And then there's now the HRT. And when we think of HRT, it's basically just replacing the estrogen. Yeah. And the estrogen will come in various forms. Comes as topical preparation, so things that you can apply, comes as a patch, comes as a tablet, and we usually will give, and dose dependent. So depending on your age and where you're at, are you still having periods? Are they light? Are you in peri or pre? Will now vary the dose of the estrogen. If you still have your uterus or you still have your womb, then it's always good to complement estrogen with progesterone. Yeah, so those are the dynamics now we'll go through with the patient and discuss and see. And then another very important thing, there's that misnomer of, HRT, it's problems. It comes because there are certain reproductive cancers, or let's say cancers that's specific for women, so breast, womb, ovary, that are driven or are sensitive to estrogen. So if there's a familial risk of certain reproductive cancers, then we will opt out of giving that estrogen. Yeah, so it's nice. So basically, it's just a conversation. You come to the doctor and say, "This is what I'm feeling. Is it normal? Is it not?" We go through a criteria, or an assessment tool, and then we see, okay, what fits. Yeah.
Right. Then in addition to what she said, when the estrogen in women goes down, you lose the protective factor that estrogen gives you to your cardiovascular health. Women are actually at lower risk of getting heart attacks than men.
Yeah.
Because estrogen is protective.
Wow.
All right. So when you approach perimenopause and menopause, we actually encourage you to start taking steps to protect your cardiovascular health. And one of those steps is maintaining a healthy weight and also maintaining a healthy heart, either through diet and also exercise. All right. And then, like she said, you see, menopause people tend to think of it as one thing. Yeah. But every woman has what bothers her.
Oh.
Besides the mainstream symptoms she has spoken about, for some women, their symptoms are muscular aches. Somebody else might be bone pain. Somebody else can tell you they're just getting electric shocks throughout their system. Somebody is just skin dryness. No matter what you apply, that skin is just dry. Wow. For others, it's excessive hair. So it's not just one thing. Or hair loss. Yes, so you can have either excessive hair or hair loss. So there are the common symptoms of menopause and there are the uncommon ones. So what we do, we tailor make a treatment depending on which symptom is a problem. Yeah. You see, even for hot flashes, there are other things, drugs we use to manage hot flashes that are not HRT.
Oh yeah, I was going to ask that because I think that's the one thing that is related to like everyone knows about menopause, hot flashes.
Yes. So it ranges from what she talked about, the phytoestrogens. If that doesn't work, you can do hormonal replacement. If it doesn't work, you can actually use drugs that moderate how your body reacts to serotonin. Okay, so there's a whole range, but you see that's targeted towards a hot flash. If somebody else is complaining about dryness in the intimate area, which is giving them trouble during intercourse or having some mild urinary incontinence or just feeling dry and irritated, we will give you a local estrogen cream to apply down there, which will sort out your symptoms. All right? If your problem is, what else? Libido. We'll give you a testosterone cream. You see, it is not one shoe fits all. We tailor it
tailor-made.
to what the patient is struggling from. And even when you use HRT, there are other compounds we use which are estrogen and progesterone-like, not exactly estrogen and progesterone. The advantage of those ones is their side effect profile is kinder. Unlike traditional HRT, which is a good thing. So we tailor make it. It's not a one shoe fits all. But I must encourage all women who are undergoing through that period. Cardiovascular health is important. Bone health is important. For bone health, you need to take some extra calcium, some extra vitamin D3, and also work out, and especially do weight training. Weight training is good for maintaining
The
bone density. Yes, it's very important. Like those are the two common problems women suffer from: the cardiovascular health and the bone health. And again, we insist we must screen for reproductive tract
cancer
and prevent. Yes.
So I think the conversation usually is people tend to think that menopause is equals to HRT, and I think what you're bringing in is a very important aspect that you cannot run towards HRT, because I think that is what I hear women tell. Oh, why am I not getting hormone replacement? Maybe you're not a good candidate for hormone replacement, and I think you can only know this when you have a good conversation with your gynecologist and you tend to understand what your risk profile looks like.
That is true. And at the risk of sounding insensitive, menopause is not a disease. It is a transition. So people should embrace it as a transition and not look at it as a disease. The same way adolescence is a transition. When your daughter tells you, oh, mommy, pimples, you tell her, mommy, it's hormones, it will. It is a transition. So even us, we usually first thing we educate women and tell them it is a transition. However, if the symptoms are interfering with your productivity or quality of life, we can give you remedies targeted to that. But embrace it as a transition. In fact, our go-to first-line therapy is, like she said, lifestyle
modification.
Yes, if the hot flashes are not too bad, a few hot flashes a day are manageable.
Can have your fun.
Yes, have your fun, have your neck fun, your short sleeve, your linen and chiffon, you know?
I think that is light.
Yes, embrace it as a transition. Yes.
When we look at this period for the perimenopause, the menopause and the post, how long, on average, how many years does this transition take?
So they say perimenopause can last anywhere between 4 to 12 years. The lucky ones get 4. The unlucky ones get 12. So it's quite a duration in time. And actually what women suffer from is perimenopause. You know, menopause is an event. Menopause is when your periods actually stop. So it is an event. But now the challenge is a transition. The symptoms you get before the periods actually go, that's what actually troubles women. Yes.
So after menopause, after these events, then more often than not, you don't get symptoms or they're not as bad.
Yes.
Oh yeah, because hot flashes no longer are there, all this.
Oh, but that said, for some women, they may persist.
Oh.
A few women, they may persist even their actual menopause for up to 5 to 6 years.
Okay.
Yes, although it's a rarity. For most women, once menopause occurs, in the next couple of months, the symptoms subside and things settle out. However, some of the symptoms persist, especially the ones which are caused by low estrogen. Like you'll still continue having dryness in the genital area. You'll still have dryness during intimacy. You'll still have challenges with your bone health. You'll still have the same challenges with your cardiovascular health. So those 4 areas still need to be taken care of.
Even post.
Yes, because you see, the transition is hectic, but even after, your body still lacks the estrogen. So you may still suffer from some of those symptoms. And in addition to that, as the pelvic floor gets weaker, you can also get prolapse of the pelvic organs. Yes, especially something we call the uterine prolapse and cystocele, which can cause a bit of difficulty. So even after menopause, the effects of low estrogen will persist, and the women now post-menopause will have that spectrum of problems. Yes, which would still need to be addressed.
They still need to address.
Yes.
Okay. All right. So thank you. I think I've also learned quite a bit from that. On fertility. So there is this, of course, we know there are some causes of infertility which we'll go through. But what is the relationship between fertility and women empowerment? We've had this conversation going, oh, career women, there's this, there's this. Maybe we could demystify all this conversation, but maybe just looking at fertility in our context.
And women empowerment. So when you're looking at this whole empowerment dynamic, women need to be cognizant that fertility of a woman does not wait for you. You have, if children are what you want, you have to factor them in early enough in your life so that you do not have trouble with having children. I am not saying it's impossible to have children in your 40s or late 30s. It is possible. But for most women, they will need a bit of assistance and maybe struggle a little bit more than they would if they had had the children when they were younger.
Earlier.
And this now brings the conversation of fertility preservation. Can you freeze your eggs? Yes, you can.
Yeah.
So if you think you'll delay for childbearing for a significant duration of time, then one of the alternatives we give is the option to freeze your eggs, which keeps your options open. However, also with freezing your eggs means the only way you'll have to have your child is via IVF, which is assisted reproduction, not the natural way. So it's a double-edged sword. As we empower women, we must also empower with education so that they're able to make the right decisions in regards to their reproductive health and fertility. Yes. So the empowering must come with education. Yes, so that a woman is able to make an informed
decision.
choice.
Yeah. All right. So Dr. Nyawira, maybe we can look at what are the common causes of infertility currently in the world that we're living in.
So I think maybe I'd use a rule of thirds. With a slight skew, there's a slight skew to women, but 1/3 is usually female, female factor, another third male factor, and then the last third we actually can be combined. Actually, it's a multi-factor, and now from there, a small subsection there is we just don't know. You check, and we don't have a reason. And even still with that, there's a slight skew to women contributing a bit towards infertility of the couple. Yeah. In our context, certainly infections play out there. So, tubes and tubal blockages are a big cause. And then just irregularities of menstrual flow is probably the next thing that fits in there as causes of infertility. Yeah. On the men's side, it's mostly on the sperms. But yeah, I think, and then on the combined side is, yes, may bring my issue and you bring your issue and we combine it. And then there's just there's an unknown group where you look and you won't find a cause that you can pinpoint. Yeah.
Okay. All right.
Yeah. I think there are others maybe.
Oh no, I think you've covered the main things, but maybe to add on with the menstrual irregularity, the background is usually hormonal problems, which interfere with the ability of a woman to ovulate on a regular basis. Yeah, because basically we say for you to conceive a child, you need to have a woman produce an egg, which is ovulation. you need to have a pathway for the egg, which is a tube. That's why she said when you have blocked tubes, you'll have trouble conceiving. And then you need to have good quality sperm so that your egg can be fertilized. And the last component is you need a healthy womb. So maybe in addition to what she said, if you have something happening with your womb that's interfering with its ability to hold a baby, it can also contribute to infertility. Commonly fibroids.
Fibroids, yes.
Big thing. Yeah, and maybe adenomyosis, but mostly fibroids.
I think fibroids are a very common thing, especially now as we're talking about women giving birth a bit later on in life. So then they've been exposed to this estrogen for a very long time. Then this gives the fibroids a very chance to actually develop. And But I think, well, those are very important things that you're bringing in. So would we say, or are we in a position to say that a lot of these factors are reversible in terms of infertility?
Maybe not reversible, but treatable. Some can be treatable. Like if you pick up infections early enough, the ones you can, unfortunately some are silent, you may spare the tubes from getting blocked. If you're able to diagnose a hormonal problem early enough and able to balance out the hormones and the woman can get to ovulate, that can solve that problem. The causes of low sperm count in men, some are treatable, some are not. So for the treatable ones, if you're able to pick them up and treat, then you can resolve the problem. If you're not able to treat, then you have to look for an alternative. But that said, even when you look at the causes, there's this obesity has become a big thing. Being overweight predisposes the woman's body to hormonal imbalance. So for some women, just correcting their body weight is enough to correct the problem that is causing them not to ovulate, and they're able to conceive a child. And unfortunately, obesity is also affecting men, and unfortunately is also affecting their sperm count. Because when they're obese, they also get hormonal imbalances that trigger poor quality of sperm. Yes, and also in our setup, we have a lot of substance use, especially alcohol and smoking. Smoking especially is not kind on the reproductive tract, both for men and for women
as well.
Yes, and also when you look at the food we are consuming, it contains pesticides, some of them which have hormonally active components, which can also cause cause hormonal imbalances or interfere with the ability of somebody to be fertile. So even how we are growing our products, the pesticides we're using, whether it's on beef, you know, the cattle, milk, chicken, even the fruits, the ones you get, you know, the nice looking ones, you know, the tomato you want to pick that's not organic, you know, the nice fat red one, or the nice big zucchini that's nice and purple. More often than not, it has interacted with a pesticide. And some of these things start affecting us. Even use of plastics is also starting to affect us. So there are a lot of things that are changing in our environment. Even emissions in the air are starting to affect us at a subtle level, but the cumulative effect of a little bit of this, then
your weight, and
in the end, you're having a hormonal imbalance and you're wondering from where. But all these things are starting to affect us.
All right. So, Doc, maybe you could highlight what kind of infections cause tubal blockage. I think that is good information for people to have, that sometimes some STIs or some sexually transmitted infections may have long-term effects that can affect fertility.
The thing is, it's a big class of infections we call pelvic inflammatory diseases. Some are sexually transmitted and some are not. The commonest sexually transmitted one is chlamydia, but unfortunately a majority are not sexually transmitted. So it's difficult to classify them all under STDs. But if you're to look at the commonest STD that causes a silent infection that causes tubal blockage, it is chlamydia. And the other thing to note is that pelvic infections in women may produce symptoms or not produce. So sometimes you may tell a woman your tubes are blocked, it was an infection, they say, I swear I've never had a discharge, I've never had a pain. But now you see you have to explain that not all the infections in women will actually be symptomatic. Some of them are notoriously silent but just fester and cause chaos. So
in this regard then, is it, or it's advisable for women to have as part of their routine wellnesses to have pelvic ultrasounds or just ultrasounds to just assess?
Yes and no. An ultrasound will not pick up all the infections. However, it can give you other information that might be useful, like if you have a problem with your ovaries, if you have a problem with the uterus. So it's not a bad tool, but you cannot use it specifically as a screening tool for pelvic infections. Yes, its utility is not suited for that. Yes.
Okay. So for pelvic infections, what would be the screening tool, or what the recommendation would be?
Again, it's a difficult thing because you said some of them, actually almost 40% are silent. Yes, you
So they
feel
can-
absolutely nothing. Because see, commonly what will bring you to the hospital to see the doctor is if you have a discharge or you have a pain, or if you have abnormal bleeding. Because those are the three ways commonly the infections will present. So when you come with that, then the doctor will start looking, where is the
What
problem?
might the problem be?
Yeah. And unless you get the symptom for women, it's actually difficult for it to be picked up. Unlike for men, where most of them manifest, only a small minority don't manifest. Yes. So it's rather unfortunate that there's no screening tool. But that said, there are screening tests for sexually transmitted infections. There are some swabs we do that give you a panel of quite a number of them. So maybe as part of your annual health, you can have that done. Or if you're having recurrent symptoms and you can't figure out what it is, you can have that done. Or if you think you have a wayward partner and you're suspicious, it's still an option. Yes.
Okay.
Yeah, so that might be a better tool. There's a swab we do that does a battery of sexually transmitted infections. It might be more useful, but that would tell you more of a lower reproductive tract, not
As
the
opposed to the
upper
upper
one.
ones.
Yes, but that's the closest we can get to a screening tool.
Okay.
Yes.
All right. So then I'd like to know what people should have in mind when they're thinking about fertility treatment, because of course we're looking at probably someone who has gone through, they've had the conversation with their gynecologist and they've gotten to a point where the gynecologist has told them then you might need to have fertility treatment. So what are some of the things that should go through, or what should someone look at?
Well, okay. Well, that one is best answered by Dr. Modhoni, actually. It's her pet subject and her interest. But let me start off by saying that it's a joint thing. Yeah. So number one, the couple should come together and be prepared to support one another. And then just give it a bit of patience. The statistics actually are not, so magical as we imagine. 50% of people trying to conceive will do so in the first half year. When you have nothing wrong with you. Like actually just give it 6 months of regular contact. You can be a bit cheeky with it and actually now figure out which days, you are fertile and ready and not. But we should moderate our expectations. That's basically the message, and come in together. Because that journey is usually, it's like, it's a me and you.
And then in addition to what she said, I always encourage fertility to be multidisciplinary. By that I mean you'll have your fertility specialist, stroke doctor. You should have somebody supporting your mental health because it can be brutal.
Okay.
You might have to work with other people, maybe a nutritionist. If you're thinking maybe it's something genetic that's causing the problem, we might ask a geneticist to come in and do for us a pedigree and we see where the problem could be at. So ideally it should be multidisciplinary. And then when you're looking at fertility, the first concept... Pedigree is when you're tracing. Remember those things used to go for Mendel's in high school? Yes, there's a thing they normally do if they suspect maybe there's something genetic going on. Yes, depending also on the history. And then the other thing to note is fertility treatment is also highly individualized. By that I mean we will consider your age, whatever is causing the infertility, your state of your health. And then when you look at all those, also your mental health status, when you look at all those things, plus your financial status and cost of the treatments, then you are able to individualize a treatment plan for you. But generally speaking, remember the way we looked at causes of infertility. If you're having trouble with making eggs, we can give you medications to support that process. They can either be tablets or injections, sometimes something to regulate your sugar levels. It's a whole thing you can do. If you're having trouble with the tubes, if it is something that can be resolved surgically, then we resolve it. If it is something that cannot be surgically resolved, then we look at a way to bypass the tube. So a way to bypass the tube, the function of the tube is to help the sperm and the egg to meet. So that process is basically IVF, where we harvest an egg from the female, we harvest sperm from the male, we make a baby, we put the baby in the womb. If you're having something that's making the womb not accommodative to a baby, we can resolve the problem or to see if we can work around it. Worst case scenario, we can borrow a womb, which is surrogacy, whereby you make a biological baby from a couple, but another woman with a healthy womb carries the baby for them until term. If you're having trouble with the sperm quality, if it is an issue we can resolve, we can give you medications to resolve that. If you're not able to do that, we can, and you still have a reasonable count, we can try IUI, which is intrauterine insemination. The whole concept is to try and concentrate the sperm levels and push them as high up the uterus as you can, which is where we put the sperm, and hope natural conception will occur. Worst case scenario, if your sperm count is very low or we have to use surgical harvest methods, then we harvest the sperm. But in this case, we'll have to do IVF. Yes. Yes, because the numbers will be low. So all these things are customized depending on the couple. And for some women where you cannot make the egg, you can consider, call them donor gametes. Like if the man, you can't get any sperm at all, surgical methods of harvesting do not work, you can get donor sperm. For the female, if despite your best efforts or their past fertility age, you can use a donor egg. Yes. So all those are options, and there are full spectrum. But I said through all this, it has to be multidisciplinary. Yes. You need somebody to support your mental health, somebody to support your physical health, plus your gynecologist, and hopefully your partner will be supportive. Yes. And then, like we said, when you're looking at fertility treatments, you have to also to look at costs, because most patients pay out of pocket. And these treatments have been quite expensive. But thankfully, we are mainstreaming infertility, and quite a number of providers are coming on board to take care of it. I think they're giving us 2 cycles a year.
Or
at least 1 cycle a year.
1 to 2. Or the equivalent of an inpatient package, because that's what I've also seen.
Which is great.
They do, most people have an inpatient package which they won't use. So if you're entitled to that, then they'll say then your fertility treatment can be equivalent to that.
So quite a number of insurance providers are coming on board, which we appreciate, because it can be financially draining. In fact, the greatest limiting step to fertility treatments in our country has actually been cost.
Cost. So and health-seeking behavior.
Exactly.
So present early if it's present
so
early.
To finish what she was saying, she said you should conceive in the first 6 months, right? So if you give it a year, 80% of people should have conceived. So if it takes you more than a year to conceive and you're below the age of 37, go see your doctor. If it takes you more than 6 months to conceive and you're above the age of 37, you need to see your doctor. When you're above 37, you're on an accelerated pathway. So if there's a... Remember we said fertility is declining, so we're on an accelerated pathway, so that if there's a problem, we're able to pick it up early enough. And if you need assisted reproductive techniques, we do them early enough. Because honestly speaking, the best time to do even assisted reproductive techniques is before you're 42.
Earlier.
Yes. So we want you to come as early as possible. So if there's a problem, we pick it up and resolve it the earliest possible. So 1 year for below 37, 6 months for people
above 37.
37. That's the time you need to go and see your doctor.
So I think that is very important, that time, because I think the challenge usually is people keep waiting, you keep trying, and then probably things are getting worse at that point. All right. So thank you so much. I think we've covered a lot of areas, we've gone through the whole life cycle of a woman, looking at the challenges, looking at what is emerging, what are the main issues. I think as the main lesson here is that there are very many areas that there is need to accelerate action, from empowerment, from policy, from just all these things, the support, stakeholder engagement. There are all very many areas that would be important for us to accelerate the conversation or the action with regards to reproductive health. So probably I'd want to get what your parting shot would be with regards to this topic and with the theme in mind for International Women's Day.
So maybe before my parting shot, I'd like us to appreciate that we have made strides. Like in terms of policy, we are increasing the maternity leave from 3 to 4 months. In fact, some counties have already instituted that. Paternity leave has been increased. Like I've told you, I'm mainstreaming infertility. Healthcare providers, especially the insurance companies. I don't know that SHA is doing it, but NHIF had started taking care of it for some patients.
Yes, it was,
which
that
is
I
a
remember.
good thing. When you're looking at infertility, I think there's a bill in Parliament on infertility, use of assisted reproduction, surrogacy, gamete donation. You see, right now we are doing it, but it's not ingrained in law.
Yes.
So we are making strides.
We are
also
for people who have pregnancy losses.
Yes, that's something that that has been
because
implemented.
initially, if you had lost a baby, you are not entitled to a maternity leave. But I
to
think we are making strides. We're recognizing this as well. And then also, when you're looking at the adolescent girl, there is a lady who is always getting pads. There are drives to get pads for these girls who are suffering with menstrual health products. We must appreciate that. Yeah, they're doing a great job. We're also having people advocating for girls to stay in school, not marrying them off. There's a whole legislation on female genital mutilation. It's actually a crime. You could actually get arrested for that.
Thanks to the Uhuru government.
So it's good to appreciate that in terms of legislation, we are making strides. Yes, it's not all gloom.
Yes, definitely.
You know, sometimes when you speak about it, you think everything is bad. But it's not all gloom. Can we do better? Yes, we can. But at least we're having the foundations of it. We're also talking about it.
Yes.
Which is
the conversations are a big thing.
Yes. So as much as you're saying there's a lot to do, we must appreciate that we have made significant progress. And I think for me, it could also be a parting shot is that we have begun. It's just now to gain momentum and maybe pick specific focus areas that will affect us. You know, like everything else. When you have a movement, there are many areas, but not all of them apply to you. So for us, we need to pick certain areas where we can contextualize to our setup and maybe build up on those areas. Yes. So I think for us, we're making progress.
So the future is bright.
Yes. It is bright, very bright.
Okay. Right.
Sure, I can't copy paste. As you said. But yeah, this is conversations that we like to have. And so maybe what I can just say, it's like, not only during this time, International Women's Day, but any other time, we'd be happy to sit again and meet with people, the audience, if you would like to
a deep dive in any of those areas.
It's any of those areas, because really we've just touched on these areas. But of course we can delve more into the deeper conversations and see where the challenges are, where the priority areas are.
We can come. I guess they can reach out to you and through Britam. We want to thank Britam, I guess, even for this opportunity. And we are at 40 Suits on the 5th floor, the Women's Clinic.
If you'd like to reach us,
come and find us.
I think for this International Women's, like the way we define reproductive health, not just absence of disease, but you need to be healthy. Your reproductive health needs to be healthy. Your mental health, and your socially also need to be functional. So actually devolving health from just looking at
physical
Yeah, I keep
It's
telling people I'm not my
physical.
uterus and ovaries. I am a whole being.
Yeah.
So we need to look at the social aspects and, like you say, the mental health aspects, and trying to look at a woman as a holistic person and how each of these spheres interact so that we are productive members of society.
As opposed to the fragmentation that we often see, or that
Yes.
you're defined by this. As a certain period of time in your life, you're defined by this. It's children.
Yes.
The next, it's that fragmentation that becomes a challenge.
No.
Yeah. So I think the main take home here would be the education and the importance of empowerment, having a conversation, normalizing having conversations with your specialists. Let's avoid this habit of always self-prescribing things, relying on information, the grapevine that we hear over social media. Let's normalize having important conversations, and these conversations also just tackling exactly whatever we are going through. So I think that will be it. This is a first of many. We are going to have a lot of more conversations around this. Thank you to my very distinguished guests for honoring
Incredible.
our invite.
Incredible.
It's incredible for honoring our invite and just pouring so much knowledge onto this topic. Thank you so much for having us. The Women's Clinic is one of our partners, so we'll have also the contacts of the gynecologist if you would want a follow-up with regards to this, where you have any questions, where you want to consult. They are also available for you to also just assist you as we go along. But thank you very much. On to the next.